HYALGAN should always be injected directly into the intra-articular space of the knee rather than into the tissue surrounding the joint to achieve maximum therapeutic benefits and minimize the risk for injection site pain. As recommended in the product's prescribing information, HYALGAN should be injected into a dry joint, requiring that arthrocentesis be performed if effusion is present before HYALGAN is injected. Let's review the basic steps to consider when injecting HYALGAN in patients who have osteoarthritis knee pain without joint effusion. I'll use fluoroscopy to help show how I approach the joint and confirm that I've accurately placed HYALGAN within the open joint space. Fluoroscopy may not be available or practical in your clinical practice, and it is not specifically mentioned in the directions for use for HYALGAN. It is used here solely to enhance my demonstration of the recommended injection technique. As you prepare to give an injection of HYALGAN, arrange the equipment that you'll need during the procedure on a tray close to the patient. Follow strict aseptic technique for the procedure. You'll need gloves as well as materials for skin preparation, skin anesthesia, the HYALGAN injection, and dressing. Draw the lidocaine into a small syringe with the 25 to 30 gauge needle. Also, attach the HYALGAN pre-filled syringe to the 20 gauge 1.5 to 2 inch needle. The HYALGAN pre-filled syringe is intended for use in just one knee. If your patient requires injection in both knees, you'll need a second HYALGAN syringe. It is also recommended that you keep needles and syringes out of the patient's direct view to help reduce initial injection anxiety. After the first injection, show the patient what just happened. Most will have less anxiety the next time. Encourage the patient to dress appropriately. If necessary, remove any clothing that may be covering the knee. Select a comfortable position that will allow clear access to the joint. For most patients who do not have a palpable joint effusion, I'd suggest a supine position with the knee flexed and the foot supported. In obese patients, however, it may be easier to establish anatomic landmarks when patients are seated with the knee bent over the side of the exam table with the knee flexed to 90 degrees and the foot dangling. In patients with no palpable joint effusion, I prefer to follow a parapatellar injection approach. If you choose this approach, palpate the joint line. Identify the soft spot defined by the joint line, patellar tendon, inferior corner of the patella, and the femoral condyle. The angle of the syringe should be approximately 10 degrees from the sagittal plane of the femur at 5 o'clock or 7 o'clock and parallel to the table. Staying above the joint line, aim the needle towards the condyle, not the condylar notch. Be sure that the selected injection site is not affected by overlying skin disorder such as psoriatic plaque or a soft tissue infection. After you've pinpointed the desired site for needle entry, use needle cap or a retracted pen barrel to mark the injection site. Apply sufficient pressure to leave a mark on the skin surface that will remain visible after sterilization to guide your injection. Use betadine swabs, betadine applied to sterile gauze pads, or an iodine applicator ampule to cleanse and disinfect area around the injection site. After applying the disinfectant, wipe the injection site with a sterile alcohol swab or prep pad. Use of subcutaneous lidocaine or a similar local anesthetic before injection of HYALGAN is stated in the product's prescribing information. I prefer to use local anesthesia to reduce patient discomfort. It's especially important for physicians who are less experienced at administering intra-articular injections and for patients who are receiving their first injection of HYALGAN. At the marked injection site, inject the knee with the lidocaine syringe. Make a small skin wheel. Advance the needle slowly, injecting as you go. If you hit bone, you've gone too far and must back the needle out of the joint. Do not inject the anesthesia into the joint itself because it will dilute the hyaluronan. Inject the remaining anesthesia as you draw the needle from the site. As you're injecting the anesthetic, you should be making a mental picture of the correct needle path for the HYALGAN. Once the local anesthetic has taken effect, usually in about 2 minutes, insert the needle with the HYALGAN pre-filled syringe through the same path to the joint capsule. Penetrate the joint capsule, go to the bone, deliver the hyaluronan into the joint at a relatively slow and steady rate to avoid resistance to the injection. If you are in the soft tissue, rotate and redirect flow by spinning the needle at 90-degree turns until free flow is achieved. Occasionally, the needle must be redirected to a less angled position. The degree of resistance that you find will depend in part on the size of the needle used. Some resistance may be encountered because of the viscosity of the product, even when you're achieving a slow injection rate. Excessive resistance is usually indicative of being in the wrong spot. Patient discomfort experienced during the injection is another indication that the hyaluronan is being injected wrongly rather than into the clear space intra-articularly. If excessive resistance occurs or the patient experiences discomfort, discontinue the injection until you have reoriented the bevel of the needle or repositioned the needle into the intra-articular space. Frequently check patients who are in a seated position during and after the procedure for signs of syncope. Clean the injection site with gauze after removing the needle from the injection site and apply an adhesive bandage. Instruct the patient to apply pressure to the site for at least 2 minutes to prevent bleeding. If the patient previously experienced an injection problem or the patient has local pain, you may also recommend that ice be applied to the injection site to minimize irritation of the soft tissue surrounding the site. Finally, request that your patients avoid overly strenuous or prolonged weight-bearing activity for 48 hours after the injection. By considering these procedures when administering HYALGAN in patients with osteoarthritis, knee pain, and no palpable joint effusion, you may be able to enhance the reliability of your injection technique. Targeted delivery of HYALGAN within the intra-articular space of the knee is needed to achieve full therapeutic benefit and to minimize the risk of injection site pain. This demonstration will hopefully increase your comfort level when injecting HYALGAN in your patients with osteoarthritis knee pain and improve their response to treatment.